Good evening, friends. So today we are going to discuss about the second part of vital pulp therapy, that is DPC, direct pulp capping. So according to Kopel 1992, direct pulp capping is the placement of medicament or non-medicated material on a pulp that has been exposed in course of excavating the last portion of deep dentinal caries or as a result of trauma. So what are the objectives of direct pulp capping? Direct pulp capping is done to create the new dentin in the area of exposure and subsequent healing of the pulp. So coming to the indications of direct pulp capping, it should be done in those area where there is small mechanical exposure and which is surrounded by sound dentin. The exposure should have bright red hemorrhage that can be easily controlled by dry cotton pallet with minimal pressure. It should have true pinpoint exposure. Now coming to the contraindication of direct pulp capping, it should not be done in those cases where they have severe toothache which resemble the irreversible pulpitis. Spontaneous pain should not be there. Tooth mobility or any kind of periodontal disease should not be there. There should not be excess of hemorrhage. There should not be discharge of serous exudate. And there should not be any kind of internal or external resorption. And there should not be any kind of swelling or fistula which resemble dead necrotic pulp. Now coming to the various technique used for direct pulp capping. First, rubber dam isolation should be done of the tooth which has to be treated. Once, if there is mechanical exposure or the pinpoint exposure, further manipulation should be avoided. And cavity should be irrigated with saline. Hemorrhage should be arrested with light pressure. And then place the pulp cap material with the minimal pressure to avoid the restorative material or the pulp cap material to go inside the pulp. And then the tooth should be sealed with temporary restoration. And in the second appointment, if there is no history of pain or spontaneous pain, then the final restoration should be done. Coming to the various histological changes, this, as you can see, this is the exposed pulp, and after placing the pulp cap material, these are the various zones formed, given by Glass and Zender in 1949, that after 24 hours, if we place the calcium hydroxide or any other pulp capping material on the exposed pulp, first the necrotic zone is formed. Then after 7 days, there will be increased cellular fibroblastic activity. Then after 2 weeks, the dentin is partly calcified with fibrous tissue. And after 28 days, the zone of new dentin is formed. Now coming to the various medicament used. This we will discuss in a separate seminar. Calcium hydroxide can be used, 4-meta can be used, MTA, mineral trioxide aggregate, laser, and bone morphogenic protein can be used. It should be contraindicated in the primary tooth because of high cellular content and the abundant blood supply and the faster inflammatory response and poor localization of infection.